Well, thank you very much, and thank you to Neil for inviting me to come here. You know, I come here not as a prostate cancer expert per se, but really as a sexual medicine doc. And as some of you know, I've been working with testosterone in one and researching it one way or another for over 40 years, starting as an undergraduate, working a few years with testosterone and lizards. And I think tomorrow I have a slide or two about the impact of testosterone on lizards. But as I started trying to figure out what the relationship was between testosterone and prostate cancer, and as it seemed to be quite different from how I was taught in my training, namely that it was uniformly bad, like the devil in terms of prostate cancer, one item that kept coming up in discussions and comments from audiences, well, okay, you've got this, you've shown us some data that testosterone may not be so bad for prostate cancer, but listen, you gotta concede that testosterone flare is really bad. And so as I started looking through this and started looking into the flare evidence and the stories around it, I thought it was really fascinating, and excuse me, thought that this meeting would be a nice place to present some of this. We've published this in Urology Focus, a paper actually with the name similar to this testosterone flare. So let's just go back. So I was a resident in the 1980s. I know it's hard to believe I look so young, but there it is. And it was an amazing time between 84 and 88. You know, the LHRH agonists were coming in, and the first part of my residency, we were doing orchiectomy routinely for the men who came in with metastatic disease. And by the end of my residency, we were doing a lot of Lupron injections. And it's true and became, you know, David Crawford earlier today showed that the serum T rises initially with the LHRH agonist before it drops. That's what we call testosterone flare. And very soon, everybody started blocking the flare because there was concern that, especially from some case reports, that terrible things happened. And I learned, and some of you look like you're my generation and beyond, is that, you know, the thing that we worried the very most about was vertebral collapse, spinal compression, right? Like, we've been talking about this for a very long time. And so now it's routine in many circumstances to use blockers to block the flare. And I just want to show you what some of the data are. So this is what I said. It became routine to start an anti-androgen together with agonists. How many people here will do that routinely for everybody that gets one of these things, regardless of stage? Some people do it based on stage and whether the guy has Mets to the bones or whatever, but a lot of people will just do this routinely for the first month. And I remember 1990, I remember when Ian Thompson presented this paper. Like, this came up in our journal club. And so these are early days of LHRH agonists, and there were 2 cases in their experience where there was death attributed to testosterone flare, and it made a big impact. It's funny, I wasn't doing, you know, I was just out. I wasn't doing a lot of testosterone yet. I remember the discussion in journal club about this and how testosterone was terrible. And so one of the cases was a guy who died of respiratory arrest 5 days after getting first injection of LHRH agonist, and another one who got shortness of breath on day 23 and died 3 days later, and neither underwent autopsy. And I'm going to come back to this, and if I don't, please somebody ask me about it. And so we see the blockers now are in guidelines about short-term administration of anti-androgens is recommended to reduce the risk of the flare-up phenomenon in M1 patients. And so ultimately the question, you know, how we've thought about this is that testosterone fuels the fire, right? Are we pouring gasoline on a fire? Are we feeding a hungry tumor, right? How many of you know that phrase? Well, all of you. And I used to teach it to my own residents when I came out, and I don't do that anymore. And I'm going to show you part of the reason why. So what is testosterone flare? So if somebody is given a GnRH agonist here, there's a rise in serum testosterone, and then it comes down, right? So we know that. But here's what I want you to pay attention to for a second. First of all, what's the magnitude of the increase? So it's about 50%. So here, if we say it's just a little bit under 400 in this particular, oh, I don't have a citation here. I've got another one coming up. It goes up to just under 600. It's about a 50% increase. How long does it last? Well, watch. So by 1 week, it's back to baseline. Peak is around day 2 or day 3. By 7 days, you're back to where you started on average. And then by another week, you're down close to castrate range. You're approaching it. So 50% increase for several days. By 7 days, you're back to baseline. That's an important way to think about it. It's a limited exposure to higher testosterone. And so there were a number of papers that really helped to solidify this. This is New England Journal of Medicine. This was a randomized trial looking at adverse effects of a GnRH analog, buserelin, in men who had metastatic prostate cancer, together with and without an anti-androgen, nilutamide. And what you see here is that this is the curve. This is median PSA, yeah? And you see that with the blocker, PSA comes down. They're starting at 0 for change, right? And it comes down quickly, and it's much delayed here. Well, how much delayed? This is about a week or so, which makes sense. And then it starts to come down. Now, there's something missing that wasn't commented on in this paper. Can anybody point out what it is? It's really important. Exactly. Thank you, Neil. So this is where we're starting with. We have flare. This is day 1, 2, 3, 4, 5, 6, 7. Where's the rise in PSA? So we would think, and we would think that if PSA is a good indicator of disease volume, disease status, right? We follow PSAs. Where's the increase? Went up by 50%. This report did say that there was some disease flare, which is that the men who were in this arm had more bone pain than these men did. But watch, but these guys dropped their PSAs right away, and these guys also dropped, but it was delayed by about 7 to 8 days. So did it get worse, or are they just comparing it to a group that got better and they were unchanged? Here's another paper from out of Japan. And again, with a blocker, without a blocker. With a blocker, PSAs come down right away. Without a blocker, it's delayed, but comes down. But where's the rise in PSA? Here's another paper using different, I'm sorry, it's blurry, but you'll get the main point. Using different strategies. So here's day 0 where they get the LHRH agonist. So here they used blockers a month before, 2 weeks before, a week before. And then here's the one that didn't get a blocker. And you can argue there's a little blip here in the PSA. Maybe it goes up. But watch, this is 20% higher. Halfway here would be 10%. Maybe it's a 5% increase. They don't have error bars here, and they don't actually do any statistics. But I think you'd be hard-pressed to say that that's going to be a meaningful or even statistically significant rise in PSA. Another paper. This is the Urology study. Can I go backwards? Let's see. No. Can you go backwards for me? 2 slides. Yeah, so this is the Mark Garnick's paper. Urology looking at an antagonist versus an agonist. And so these guys all got, this is the antagonist, shows PSAs coming down, And this is the group that got either Lupron or Gaserelin. And again, there's essentially no change here. So look at the error bars here. I don't think that that's any higher. Eventually they get there, but there's no disease flare here either. So PSAs didn't go up even though testosterones went up. There is one of these papers that we identified where there is a rise, and it's not a controlled trial. So we see here it was 100%, and it goes up here by about 20, 25%, and then comes down. So 1 out of 5 papers that we found around this showed that there was something. Now, this is one of the best. I think this is an amazing paper. 1989, Peeling. And it may be interesting to many of you here. So they did a big study. They had a lot of people in here, especially for this time. And the key item I want to show you here is Zoladex, right, agonist, versus orchiectomy. So what does orchiectomy do? Testosterone is going to go down right away, right? That's the source of it all. And what you see here and what they found is that there was nothing terrible that happened to these men who got an agonist versus this. They saw more increased bone pain, but remember, it's going to be, the drop is going to be delayed by 7 to 14 days or so. But they didn't see nodal obstruction. These are all guys with advanced disease and metastatic disease. And here's something really interesting, is that paraplegia did occur. But they had one case in both. This is within the first month of treatment. What's the significance of the paraplegia in the orchiectomy group? The significance is that if you have diffuse bony mets from cancer, bad things are going to happen to some of them. It's part of the natural history of having that disease. And when we started, how many years ago is it now? 30 plus years ago, with the belief that testosterone was the devil. Anything that could be attributed to a rise in testosterone was attributed to a rise in testosterone. So if we go back to Ian Thompson's case reports, where somebody died suddenly at day 5, no autopsy, we don't know why they died. And then somebody developed shortness of breath on day 23, when his testosterone would have already been at castrate levels. The flare's over. We say this happened because of testosterone flare, and in 1990 that was easy for all of us to believe. I believed it too. But today, knowing what we know, it actually doesn't really make much sense. Could it just been the natural history of the disease? Could have been an MI? We don't know. PE, these guys had bad disease. That's why they got their GnRH agonist to begin with. So shouldn't a sudden spike in T cause PSA flare? Well, we would always think so, but the way I understand this really, and we put this out first in 2006, and then here's a graphic we put out in 2009 with Abdul Traish, which I think of the saturation model, I think helps to put some of the testosterone stuff in a framework that makes sense. We used to believe that if we were to graph testosterone levels versus anything bad about prostate like PSA, volume, and this is true for benign prostate too, DNA synthesis, that the curve would go up and up and up and up and up forever to infinity. We thought that higher testosterone should be associated with worse grade, with worse stage, with doubling times, with anything bad. And in fact, what we find is all the available evidence is that for most of the range of testosterone, there's nothing different between a guy who has high levels or mid levels or low normal levels. But if we drop testosterone enough, for sure PSA declines. So we see that in our patients who get agonists and antagonists, right? PSA goes down. But that's not just a prostate cancer effect. That's an effect even in healthy volunteers who get LHRH agonists. Their PSAs will also shrink, and their PSAs will go down to undetectable or close to undetectable levels. And if you do intermittent LHRH agonist therapy, or in a study in those healthy volunteers, if you stop the suppression of their testosterone and testosterone rises, PSA will rise too, for sure. Like, that's real. But it doesn't go on and on to infinity, because it's what we call saturation. Enough has happened. Can't do any more. And if you look at, these are the 3 lobes of rat prostate. If you look at binding of androgen to the androgen receptor, if you look at the specific binding, which is here, what you see is that there's a big curve, and then it plateaus here at about 2 to 3 nanomoles per liter. Here, the same thing, specific binding, rises, plateaus through a big range here. And in the rat, that's at about 2 to 3 nanomoles per liter, which is about 60 to 90 nanograms per deciliter. Rats don't have sex hormone binding globulin, which is sort of part of the reservoir that humans have when we measure a total testosterone. In humans, the saturation level seems to be at around 250 nanograms per deciliter. So it's low, but it's not that low. And Lenny Marks, I know, is speaking here. He's not here, I don't think, now. But he published in JAMA 2006 a remarkable study where this is not cancer patients, but he just took men who had low testosterone. He put them on testosterone injections for 6 months, and he did something really clever, which is he got intraprostatic. He measured intraprostatic concentrations of testosterone and DHT, and also looked at a couple of genes that were turned on by androgens in general. And what you see here is that in, let me get this right, prostate tissue. So there's another slide that shows that testosterone, in fact, goes up in the blood, but the testosterone levels in the prostate did not change from baseline to 6 months, and DHT levels, and DHT, of course, is the primary androgen in the prostate, also did not change, even though serum levels went up. So I would love to have Lenny explain what he thinks is going on with this, but what it suggests is that the prostate is sort of its own little hormonal environment, if you will, and the changes in the serum are not necessarily reflected accurately one-to-one in the prostate. So let me show you how the saturation model in action. This was a gentleman, I think he was about 70 years old. The date here is 2007. It was, for me at least, the beginning of active surveillance, early days, and where I also started offering it to some men who went on testosterone therapy. So this was a gentleman who'd about 70, who'd been on testosterone for about 20 years. At some point, his PSA rose to 6.4. He was biopsied. He had Gleason 6 cancer. We were still worried about Gleason 6 cancer in 2007. And he didn't want treatment. Fine. But his doctor said, I can't give you testosterone anymore. You've got cancer. He went to a couple of other doctors. Nobody would give him testosterone. He came to see me. He said, listen, my life is miserable. You got to treat me. And when I saw him, his testosterone had dropped down to 64. That's his normal endogenous level of testosterone. He doesn't produce it well. But watch what happened to his PSA. His PSA here has dropped from 6.4 down to, I think this is 2.3. Because he's testosterone deficient, he's below the saturation point. I treated him with testosterone, and watch what happens. Each of these bars here is a month. His PSA rises and doubles, in fact, within about 3 months. He's got a PSA doubling time of 3 months. He should be dead tomorrow. But watch. What happens to his PSA as we make him androgen replete, full again? We've filled his tank up. He approaches where he was, and he never goes past it. This gentleman, this is 2008 now, he died about a year ago. He was on testosterone the whole time. He never, his PSA never went above 8. He had a few different additional biopsies, Gleason 6, and he died of renal failure, actually. But the point is that if we drop testosterone enough, PSA will decline. PSA is an androgen-driven product. You need androgen to actually make PSA, whether you've got cancer or not, which makes it a little bit confusing to understand where we are with some of our patients who may have metastatic disease. You deprive them of androgen and their PSA goes down to undetectable levels. Does that mean that they don't have any active prostate cancer anymore? Well, actually, if you give them a little whiff of testosterone, you'll see their PSA can go sky high again. I'm not sure that those cells are dead or inactive, but they're just not making PSA. And then some data that relates to this is tomorrow I'm going to be talking about giving testosterone to some men with advanced prostate cancer, including a limited experience in men with metastatic disease. But some of the story here is this is men we published together with Larry Lipschultz and Mo Kira at Baylor. We had 13 men published in 2011 who are on surveillance, who we gave testosterone to. All but one, I think, were Gleason 6. There was 1 3+4 in here. All these men had follow-up biopsies, an average of 2 per person. Median duration of testosterone was 2.5 years. These guys were on this not as part of a study, but basically this was just an accumulated group who said, will you please study me? Will you please treat me? And the fellow I just showed you before who lived another 10 years was part of this group. So they all had symptomatic benefit, which is why they stayed on it, but not one of these men had progression of their cancer. And look what happened to their PSA. So this was their PSA at baseline when they were diagnosed, and this is after 3, 6, 12, and 24 months of testosterone therapy. So the PSA did not rise in these men with active prostate cancer that was untreated. Now, what I like to say about this experience was it's only 13 men, and there's no way I can say based on 13 men that testosterone is not dangerous for prostate cancer. But remember where we started with this story. Where we started with this story, all of us, was the belief, the certainty, that raising testosterone in men with prostate cancer would necessarily cause those cancers to grow or become more aggressive. These are the first data, 2011, that anybody ever bothered to look at what happens in the prostate of men with cancer if we raise their testosterone. And in this group, nothing much happened. And so although I can't say it's safe, what I can say that our old concept that testosterone raising it necessarily causes prostate cancer to grow cannot be true. Not as a general statement. There may be some exceptions. This is a follow-up study we did just with our own group at Beth Israel Deaconess. And so we took 28 men that we have on active surveillance at this point, Gleason 6 in 22, Gleason 7 in 6 of them. Median treatment was, I believe, 3 years here. And we compared them with 96 men on active surveillance who also had low T at our home institution, followed by one of the other doctors. They all had low T, but he didn't believe in testosterone therapy. I don't blame him. It's a new thing in terms of men who are on active surveillance. And we looked at progression rates based not only on increase in grade, but also number of cores, percentage of the cores. And the rates of progression were basically identical in the two groups. With testosterone on active surveillance, no testosterone on active surveillance. 3-year follow-up, no PSA increase in the group that got testosterone. So, a couple of points just to, this is, I think, a little bit less of an issue for us now, this testosterone flare, than it used to be. We see so many fewer men presenting today with late-stage disease, vertebral mets, first getting LHRH agonists. But I think as Scott Lucia showed in some of his data yesterday, now that fewer people are actually getting PSA checked, especially out in the community, we start seeing some men with more advanced disease at presentation. I don't do a lot of medical legal work, but I do a little bit, and often it's related to testosterone and prostate cancer. And just in the last couple of months, I was presented with 2 cases, primary care doctors who started somebody on testosterone, didn't get a PSA. One of them in his deposition, a family doc, said, U.S. Task Force on Preventive Services said, don't get it. I don't believe in PSA. Didn't get it. The man eventually, for some reason or another, ends up with a PSA of 22, has Gleason 9 cancer, positive margin, seminal vesicle invasion. Like, you know, he's in a bad situation. Might have been curable before. So we might see this again as the pendulum swings. So, but the main reason I want to talk to you about it is that these are a lot of what we do in medicine. We like to think that we're all super smart, super evidence-based. In fact, a lot of what we do is based on lore. Lore. We were told something 20 years ago by somebody we really respected, who learned it himself from somebody else that he really respected, who learned it from somebody else who just made it up. That's what a lot of medicine is. I can't tell you how many things I learned from my chief resident when I was a junior resident. I didn't go and check on everything he told me, and a lot of it was, you know, was BS. It got me through, and that's what we do. And we take these things then into our practices for the next 10, 20, 30 years. And the reason it's worth going after it is that the myth of testosterone flare has been one of the arguments that testosterone must be bad for prostate cancer. I've now shown you the data around testosterone flare. It's not so. Now, could there be somebody who has a really low testosterone? Yes, below the saturation point, who if you give him testosterone will still have potential capacity for androgenic stimulation, further androgenic stimulation of his cancer, and something bad may happen? Yes. And in fact, I don't want you to think that testosterone doesn't do anything to anybody. Of course it does. If you start off androgen deprived and you give that man testosterone, you still have a long potential for something bad to happen. And those data exist from the 1960s, where they were playing around with testosterone in men with metastatic disease. And men who had been androgen deprived or castrated, which was usually what they did, some of those men who had had benefits from androgen deprivation were given testosterone, and bad things happened to them. They died, prostatic obstruction, things like that. But as a general concept, if your testosterone isn't that far depleted, it looks like there's not that much that happened. So we see PSA flare observed in only 1 out of the 5 studies I showed you. Disease flare is not clearly demonstrated. Now, what I mean by that is it was reported in that Kuhn, that New England Journal article, that they had more bone pain. But remember, they were comparing a group where the bone pain improved right away because testosterone was blocked right away, compared to another group where essentially nothing much happened for another 7 to 10 days. So I don't know about that. And what you'd really want to do is you'd really want to look at when the benefits, you'd want to compare it compared to men 2 weeks after they got unblocked GnRH agonist. The episodes of major adverse events like spinal cord compression, if something bad happens with unblocked flare, testosterone flare, may just be the natural history of advanced prostate cancer. We've attributed this, if the men got unblocked GnRH agonists, to the agonist and the flare, but we don't know that's true. And the use of antiandrogens at initiation of LHRH agonists may provide more rapid benefits. I mean, that's true, right? Like if you've got somebody who's got bone pain, then you may get a quicker response if you use an antiandrogen. But a lot of folks that have traditionally for the last 20 years been getting antiandrogens, often they're asymptomatic, they've got a biochemical recurrence. Like if they have they don't have pain, they're not about to get ureteral obstruction or prostatic obstruction. And if they have several days of increased testosterone, I'm not sure it's going to do much for them. So the final conclusion is that the dangers of testosterone flare, I believe at this point, is not supported by the evidence. Thank you very much.